inflammatory in origin, it is progressive in nature, and it is a result of some kind of exposure to a noxious particle. It is interspersed as the disease progresses. It is interspersed in between with exacerbations and may have poor prognosis or a prognosis also controlled by associated comorbidities. So two things are clear. One, patient symptomatology plays a bigger role here. And secondly, exacerbations predict rather poor outcomes. So patient declining lung functions, increased patient symptomatology, and increased exacerbations are three pillars which a physician focuses, or rather healthcare provider focuses in providing an optimum management for their patients. So what are the risk factors? Majority of it is due to smoking in this country. But if you go outside in the rest of the world, exposure to indoor biomass pollution is also a rather important factor. Similarly, occupational exposures, you inhale something which goes into your lung, irritates your airways. It is a progressive inflammation. Long-standing asthma, now we understand, if it is untreated, can become a fixed disease. One distinction between asthma and COPD for us today, asthma is more of an eosinophilic or Th2 cell disorder. It is reversible in nature, whereas COPD is progressive, increasing destruction. We can halt it, we can't kind of reverse the process completely. And just to keep it in mind, bring it to your attention, 3% of COPD in this country is genetics. That is due to alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency related COPD usually occurs in younger population, around 20 to 30 years of age. It also is more lower lobe predominant as compared to COPD, garden variety COPD, which is an upper lobe predominant disease. I want you to think of this way. Diseases that we inhale, they go to the upper lobes. Diseases that we inhale, they go to the upper lobes. Silicosis, asbestosis, pneumonia, viral diseases, COPD, primary lung cancer, all upper lobe disorders. Diseases which come to lung from blood flow. Metastatic disease from disorders below the diaphragm, uterine cancer, colon cancer, things, etc. Lower lobe predominant disorders, and alpha-1 antitrypsin, though the alpha-1 antitrypsin is actually made in the liver, and there is more blood flow to the lower lobes, the COPD that gets associated with alpha-1 antitrypsin deficiency is a lower lobe predominant emphysema. So how do these patients present? They either present with cough, sputum, or shortness of breath. In fact, the bread and butter of pulmonary cardiology and even primary care practice is shortness of breath. And thank God for dyspnea. No Google algorithm will ever be able to demystify or come up with a proper protocol and management of dyspnea. No Watson computer can come up with an actual plan for this. So those who do primary care, those who do pulmonary will always be in jobs. I can't say that about radiology. I hope there are no radiologists in the field today. So these patients either present with shortness of breath, which at times initially is only on exertion, but as time passes, it becomes more and more pronounced. The first presentation usually is cough, which usually is not productive. Interspersed in between, whenever these patients will get exacerbation, they may have increased sputum production as well. COPD is an expensive disease. It is one of the 5 more common diseases that we deal on a day-to-day basis. $36 billion in terms of hospitalization and absenteeism is not a laughing matter. It results in more than 13 million office visits. What do I take from this message, from this information? That this is a disease of primary care. There aren't enough pulmonologists to treat each of these patients. So it behooves upon those who are doing primary care and physician extenders to be able to at least diagnose and start treatment for these disorders. A rough estimate, around 15 million of these patients are still not diagnosed. Why is that? Maybe The healthcare providers are responsible. And the three main reasons why we are not able to diagnose is one, time limitation, or failure to probe at risk about patient symptoms. Let me ask a question. When the patient comes to you in the office and they start sitting down and then they start saying their complaint, how much time does it take for a physician to interrupt their patient or healthcare provider to interrupt their patient? Has anybody thought of it? I'm sure we all are very conscientious healthcare providers. Anybody? Give me a number. Say that again. 30 seconds. Anybody take us up and down? 20 minutes, seconds. Anybody else? It's been studied. For sake of time, it's been studied. It's a paper in JAMA. The actual timing is 18 seconds. When the patient comes, gives you your complaints, we interrupt them within 18 seconds. And what does that interruption mean? At that time, you've already figured out in your mind what you're going to do for that patient. The rest of it is tuned out. You do this. Patient says his complaints and all that. I'm not trying to make a kind of a joke out of it, but the fact is, that is the nature, the way we practice medicine. Let me ask you a different question. In the era of EMR is a necessary beast that we have. How much of percentage of your time that a physician or a healthcare provider actually spends with the patient eye to eye? What percentage of time? Usually they spend around 4 to 5 minutes. What percentage of time is spent looking at the patient and what percentage of time is spent looking at the EMR or looking at other things, calling for help, et cetera, et cetera? Ever thought of it? Again, it's been studied. The best that physicians do is 55% of the time is spent in looking at the EMR, away from the patient, and other things. So the point I'm trying to make, that the physician-patient interaction today has become a casualty, the way we practice medicine. So we have to be rather more careful about listening to the complaints of dyspnea, shortness of breath, or be able to elicit that from your patients. Okay? You can say, these things are maybe not negotiable. I am a very good physician. I still try to do the best that I can. What about spirometry, which I feel has a rather important role, and we can make a little bit of improvement in that. Studies show that still there is lack of universal acceptance of spirometry amongst healthcare providers. What about the patients? I don't know about you, but in my own hospital, if there's a code on the 9th floor, I run up and I become short of breath. What do I think? Yeah, it's normal. So majority of the patients, when they initially have a disease process for which the presenting complaint is exercise-related dyspnea, generally ignore it. So most of the patients with COPD usually present to their physician when the symptoms are rather more pronounced. We can do a little bit better with educating our patients as well, as we will see. So here is a triad. Today, everything that I talk about would be in terms of 3. Shortness of breath, cough, sputum. Take one of these. Presence of or history of past exposure to smoke or secondhand smoke, exposure to anything else, biomass gas, etc., or outdoor pollution. Take one of these present. We should think in terms of spirometry. Spirometry is the way to diagnose the obstructive lung diseases, both asthma and COPD. And in COPD, the post-bronchodilator, the FEV1 obtained after bronchodilation will not improve. Let's look at it. So let me take a poll. How many of you actually do a spirometry in your office? Fairly good number, maybe say 50%, et cetera, et cetera. Good. But when we looked at as to what is stopping from healthcare providers from using spirometry, it's rather clear. Unsure about the impact on the care, but rather more intriguing are the last two, concerned about the quality control and cost of the equipment. Physicians screen for a disease if 2 things are satisfied. One, there is a disease, there is a treatment for that condition, and secondly, there is a decent reimbursement for that screening. Both are satisfied for COPD. The equipment today is not that expensive. The maintenance is rather easy. This is one thing which can easily be incorporated into any primary care practice. It's a simple maneuver. Patient has to take a deep breath in and exhale out into the machine, and it has a little computer in it which takes the inspiratory and expiratory flow, gives you some numbers which we will look at, and now the diagnosis can be obtained. Okay, I'll go a step further. How many of you have memorized all the 69,000 ICD-9 codes? Not possible, not possible. But here there are certain codes for performing spirometry. If I were to use spirometry in my office, I will always do pre and post bronchodilator, FEV1. Why is that? Because in basic patient with asthma, there is a significant improvement in FEV1, and you have to be more precise, 200 cc improvement and 12% improvement in FEV1, whereas COPD patients, even if you give them a bronchodilator, it does not improve. And if I get a little bit more sophisticated, I will also do a vital capacity. The point I'm trying to make is there is a decent reimbursement available. It takes only another 4 or 5 minutes of your physician extender's time to capture this information. One, it will confirm presence of obstructive lung disease, and if you do a pre and post bronchodilator challenge for which there is an extra reimbursement, it will differentiate between asthma and COPD for majority of your patients. Okay. So what is spirometry? I would like to give you a little crash course. Patients with obstructive lung disease, they will tell you, they can take a deep breath in. They can't breathe out. And if you remember from medical school, in airway disorders, problem is exhaling out, not inhaling in. Let's take a right hand. Everybody take the right hand, please. Put it on your neck. Squeeze as hard as you can. This is how a COPD patient feels all the time. Point well taken. Okay. The spirometry is not that difficult. Most people think that there will be a quality control and they probably will do the wrong measurements. No. Let's take a deep breath in. We inhaled our lungs. We are at our total lung capacity. At this point, we breathe out as fast, as much as we can. If you do yoga, you do better. But I hope everybody realizes that if you inflate your lungs as much as you can, it takes around 6 seconds to come down to what is called as your residual volume. And the maneuver that we did is called as vital capacity. You went from here to inflating, to coming down up till here. This is called as forced vital capacity. But you and I have already agreed, patients with obstructive lung disease can't exhale out. This time we'll do another maneuver. One more time, please. Work with me. Take a deep breath in. Total lung capacity. Breathe out as fast as you can. Okay. I hope everybody appreciates that we exhaled out most of our lung volume within the first second. And this is called as forced expiratory volume in 1 second. So the ratio between forced expiratory volume in 1 second divided by the vital capacity is 0.80. That is normal. Saying in another word, you exhale 80% of your vital capacity in first second. And that's all we need to see. And if our patient's FEV1 goes down, then the ratio goes down further. So normal FEV1 to FVC ratio is 0.80. To diagnose obstructive lung disease, the ratio is less than 0.70 for COPD. This slide also helps remind some certain things. As the FEV1 goes down, patient's severity of disease increases. So, folks, spirometry helps me diagnose my COPD. It also helps me prognosticate my patient. If FEV1 is less than 1 liter in your patient, he has significantly severe COPD, his lifespan is significantly curtailed. And it's important for me and you as healthcare providers to tell the patient, wherever we got you, when I first diagnosed, my job is to make sure I stabilize your lung function as much as we can. So spirometry allows you to diagnose the patient. It allows you to kind of prognosticate your patient as well. It's not a very difficult test, can be incorporated in any outpatient practice. Same thing here. Most patients, if their ratio is less than 0.70, but FEV1 is more than 80% predicted, they have very mild form of COPDs. These are the patients who have very minimal dyspnea. They may not even complain to you when they come for their screening, for their annual visits. Patients whose FEV1 is between 50 to 80% of predicted, they are a little bit more symptomatic. Between 30 and 50% of predicted, they are more short of breath. And though less than 30% are very short of breath, they belong to a pulmonologist office. I do want to point out, what do I mean by predicted? Every spirometer has an inbuilt computer, and we can predict everybody's FEV1 based on height, age, sex, and race. I repeat, height, age, sex, and race. Please keep in mind, BMI does not play into this. So depending upon when you're actually going to do the spirometer, you will punch in patient's age, their race, their sex, and then it already knows what is the expected FEV1 for that patient. And whatever number that you obtain, it gives you a predicted value. And depending upon the predicted value, if your FEV1 is above 80%, you kind of are normal but minimal COPD. If your FEV1 was less than 0.70. 50 to 81, moderate. Then 30 to 50, severe. And less than 30, significantly severe COPD. All right. This paper came out last year, and I think it caused more confusion than help. It shows that this is from the US Preventive Service Task Force. They looked at patients and then said that we can't be screening everybody. I can't agree more, but also disagree at the same time. If we were to screen everybody coming through your door and start doing spirometry and that, obviously, you will not be able to pick up that many patients. Epidemiology has taught us screening low-risk patient does not increase the yield. The concept has to be case finding, and that's been supported by GOLD guidelines as well. This US Preventive Service Task Force guidelines did not say a negative value. They'd say we did not find any help with that. But yes, if you screen everybody that comes to your office, probably spirometry is not the way to go. But if you screen your patients, or case finding is that kind of screening in which you specifically diagnose patients with the intent of treating, you would certainly increase the yield. Remember, there are 13 million more COPD patients who have not been diagnosed as of today. So how do we do that? Asking about history of smoking, or you can develop a little bit questionnaire like this. This is one of those which asks 5 questions. Have you ever lived or worked in a place with dirty or polluted air, smoke, etc.? Does your breathing change with seasons? Does your breathing make it difficult to do things like carry heavy loads, etc.? Compared to others of your age, do you tire easily? And lastly, in the last 12 months, how many times did you miss work, school, etc., etc.? If 2 of these 5 are positive, and if you do a spirometry on those patients, the yield of diagnosing COPD will increase tremendously. Okay. With that little information, I kind of want to take one question. June is a 54-year-old woman with a past cigarette smoking history. You've confirmed a diagnosis of COPD, i.e., the ratio is less than 0.70. Her predicted FEV1 is around 60%. She reports breathlessness with COPD assessment test called a CAT score of 20 and modified medical research council dyspnea score of 3, which has mild sputum, no exacerbations, hypertension, osteoporosis, and some medications. At present, no history of wheezing. What is the patient's global obstructive lung disease guidelines grade? A, B, C, and D. A little louder, please. Yeah. As we go near to the hour, the importance for the food goes down, the importance for the lecture goes up, and the importance for the lecture goes down. I know that. Okay. So half and half, we are split there. So let us see. How do we define our patients into A, B, C, and D? Okay. Remember, we diagnose our patients on spirometry, but we make decisions in terms of management on the basis of patient symptoms and exacerbations. We divide patients into A, B, C, and D. Group A are those patients who have less symptoms, and means very little dyspnea and very little symptoms on combined assessment tool, less than 10 on that. Group B are those who still have very little who have more symptoms but less exacerbation. Group B are those who have more symptoms of dyspnea and assessments and symptoms, but still have no less than 2 exacerbation rates. Group C are those who have low symptoms, higher exacerbations. Group D are those who have more symptoms and more exacerbation. One more time. Group A are those who are not short of breath, and they have had no exacerbations, though on spirometry they have obstruction. Group B are those who are symptoms are high, more short of breath, but they do not have higher exacerbations. Group C are those who have less symptoms, more exacerbations. Group D are those who have more symptoms and more exacerbations. This is how I want you to look. A are patients who are usually asymptomatic. Most of these belong to primary care. B are those who are symptomatics but have no exacerbations. They still, majority of them, see primary care physicians or healthcare providers. C have more symptoms, less symptoms, but they have exacerbation in the last 2 years. They may be in primary offices or may belong to pulmonologist office, but D are those who have more symptoms, more exacerbations. They belong to the hospital and they belong to the primary care, to the pulmonologist. But folks, it's a triangle. A group forms majority of the COPD patients. Group D forms tip of the icebergs, but they utilize a lot more healthcare resources, and A are needing to be discovered. So our patient, if you look at, had symptoms, had more symptoms. Let me go back. Had more shortness of breath, 3, and more score. So our patient belongs to group GOLD guidelines B. All right. The same thing has been put together here, and our patient had MMRC dyspnea scale 3. If you look at it, it's no need to remember it. 0 are symptoms, have no trouble on shortness of breath. 4 are short of breath, even at milder work, etc., etc. So what about combined assessment tool? Do I remember it? Absolutely not. But yes, is it in my outpatient is available? Yes. Patient can fill this form. It's a Likert scale, 8 questions. As you can see, they can answer on these 8 questions related to their day-to-day activity. If the score is more than 10, they have more symptoms. So since our patient had high dyspnea score, high CAT scores, but had no exacerbation, patient belongs to GOLD B. All right. So how do we treat our patients? We have already agreed we look at the dyspnea and exacerbation, patient symptoms and exacerbations. And I want you to think of treatment in 2 different ways. One, to treat just the dyspnea. And that can be either short-acting beta agonists, short-acting muscarinic agents or anticholinergics, long-acting beta agonists, or long-acting muscarinic agents. A little editorial here. Patients with COPD are usually 60 and 65 or older. They also have significant cardiac comorbidities, so using muscarinic agents or long-acting muscarinic agents probably is a little bit better than using standalone long-acting beta agonist agents. So for early disease, patients really asymptomatic, we will start with short-acting bronchodilators, then LAMAs, then LABAs, and then ICS. On the other hand, we can stabilize patients' lung functions, at least using inhaled corticosteroids, after we have exhausted LAMA and LABA options. And in very severe patients, we'll use roflumilast, which actually just decreases the exacerbation rates, and sometimes add azithromycin. Now, azithromycin, everybody knows, is a macrolide. Everybody thinks it's an antibiotic, of course, but over and above being an antibiotic, it does have anti-inflammatory properties. There is some data to show that it very, very severe COPD, it may have some role. I don't want to go away. Each medication has its own side effects. Tremors with beta agonist, dry mouth, glaucoma with anticholinergics, increased incidence of pneumonia with inhaled steroids, diarrhea with roflumilast. I want to point it here. It causes weight loss in patients who take it for a long period of time, and azithromycin may cause hearing loss in our patients. So it's treatment you have to tailor-made with patients' comorbidities when you decide what treatment are we going to start. So as of now, for COPD patients, we diagnose on PFT, we look at their exacerbation rates, we look at their dyspnea scores and CAT scores, and we start with short-acting muscarinic agent or SABAs, then LAMAs, then LABA, then add ICS and go forward. Okay. June, let's take a question here. June is a 54-year-old patient with history of smoking, confirmed COPD, CAT score of 20, dyspnea score of 3. You diagnose this patient as Gold B. Current COPD medications include short-acting beta agonist, PRN. What should be done next? Add a SAMA, add LAMA-LABA, add ICS-LABA, or add roflumilast.
And although this wave is stringing us along, just know you're not alone, 'cause I'm gonna make this place your home.
Okay. The answer is correct. Because this patient has Gold B, we will start with LAMA and then quickly move on to LAMA and LABA combination to help with our patient's symptomatology and exacerbation rates. Okay. So for Gold B, the treatment is LAMA and LABA. And this is how it played out. In Group A, or rather the Group A of patients' GOLD guidelines, you will use Group A, we will use a short-acting beta agonist or a short-acting muscarinic agent. Group B, choices between LABA and LAMA. I told you LAMA a little better choice because patients do have underlying cardiac comorbidities, but most patients you will need to use LAMA and LABA. Group C, patients again, few symptoms but higher exacerbation rates. You will start with LAMA, again go to LAMA and LABA, and if because of some comorbidities we can't use it, you can then use LAMA, LABA, and ICS. We also know, there is data to show as the symptomatology increases, and this one study which shows that when patients' symptoms improved, they did better on the dual combination therapy. I'm repeating myself. When patients who have A or B, Group B, minor symptoms start with LAMA or LABA, either of them, but they will all need ultimately LABA and LAMA as dual therapy in Group B. Okay. Let's move a little forward. This time, James is a 63-year-old male with a history of cigarette smoking, known COPD, a little bit worse FEV1, so a little bit more advanced disease. His symptoms are again high CAT scores and high MMRC score. And he has had 2 episodes of bronchitis in the last year requiring oral antibiotics. So here our patient has not only higher symptoms, but higher exacerbation rates. He has significant comorbidities. He's only on SABA and LAMA. And his baseline oxygen rate saturation, borderline. So let's see. I won't repeat the question. What therapeutic recommendations you will give for James at this point of time? Add only a LABA. Remember, he's only on LAMA at this point. Add LABA to this. Or you will add theophylline to LAMA. Or because metoprolol can cause bronchoconstriction, you'll discontinue it. Or you'll discontinue everything and start an inhaled corticosteroids. Music, please.
Without this, worse off. Where all of the people go? I've been changing channels, I don't see them on the TV shows. And where'd all the good people go?
Okay, 57%. Again, I want to just dwell on this question. Patient had high CAT scores and high dyspnea scores. So he had high symptomatology. He also had 2 episodes of bronchitis and 1 hospitalization. So he had high exacerbation rates as well. So he kind of belongs to group D at this point of time. Higher exacerbation rates and higher symptoms. The algorithm is LAMA. Then you will add LAMA and LABA. Short-acting beta agonist, you will start with LAMA, then LAMA and LABA. If you can't use this, you can also use LABA and ICS, and then you will move on to the 3-drug therapy. A little change here. Remember, in asthma, we are very big with inhaled corticosteroids to be start earlier. I want to make a little distinction here. For COPD, we start with SABA, then LAMA and LABA, and then comes inhaled corticosteroids. In very severe patients, you may need all 3, but you will start with LAMA first, then LAMA and LABA, and see if they're stabilized, and then move on to the 3 combination, LAMA, LABA, and ICS. This is how, and if that doesn't help, some patients who have very high exacerbation rates, we will add roflumilast, or we will consider macrolide as in modifying therapy, but not till the time we have maximized on these 3 drugs. All right. So where does this data comes from that LAMA-LABA is probably the next after LAMA, even in severe disease? It came out from this trial. If you look at the probability of exacerbation, these are the patients who are on salmeterol and fluticasone, which is inhaled steroid and beta agonist, LABA and inhaled. Their exacerbation rates are higher as compared to indacterol and glycopyrronium, which is a LAMA-LABA combination. So folks, in the last 2-3 years, we have moved away. We now feel LAMA and then LAMA and LABA should be the first choice in patients even with severe disease as well. And the winner on this trial was LAMA and LABA. So SABA, LAMA, LAMA-LABA, and then we will get all 3. Similarly, there is some data on this about inhaled steroids as well. This is a different kind of trial in which patients were randomized to receive an inhaled corticosteroids and LABA against a usual care being provided by primary care physicians in England. And it did show that as compared to usual care provided by physicians, ICS LABA was also better. That's why it made into the guidelines that we can use this as well. Remember, I showed you LAMA, LABA, and if there's a contraindication to LAMA, you can then use ICS and LABA as well. But at the end, patients with group D will require LAMA, LABA, and inhaled corticosteroids. So why are we worried about inhaled corticosteroids? Because there is signal to show that patients with severe COPD, where we like to use it, there is a slight higher incidence of pneumonia. And the risk factors for pneumonia are older age. Now you and I agreed, COPD is a disease of 65 years and older. Why is that? We smoked from 20 to 30, come back to our senses, we stop. It takes another 30 years for the COPD to actually develop. So by the time patients are in their 60s, they start getting diagnosed with COPD. Low body mass index and a very severe COPD. 3 risk factors that you would keep in mind in patients who have inhaled corticosteroids are at risk for developing pneumonia when they get started on inhaled corticosteroids. So, given this information, and the patient was started on LAMA and LABA, the combination helped his breathing better. Over the past 6 months, he had another episode of bronchitis treated at an urgent care center. He does not have chronic sputum production. Okay, now the question. So your patient, James, significant symptoms, we agreed, started on LAMA and LABA, initially gets better, and now he's treated at an urgent care center with episodes of another bronchitis. What therapeutic options would you recommend for him at this point of time? Review the inhaler techniques, add inhaled corticosteroids, add theophylline, 1 and 2, or 1, 2, and 3. Pick and choose.
Start to make it
Half the people chose the right answer. We agreed in this patient-centered outcomes, SABA, LAMA, LAMA-LABA, LAMA-LABA ICS. But there's a caveat to this. Everett Koop, our previous Surgeon General, told us medications don't work in patients who don't take it or who don't take it properly. And the general practice, this algorithm works. But I think as primary care physicians, we must make sure that the inhaler is being taken properly. So in all our patients, we must review the inhaler technique as well. And since our patient was on LAMA-LABA and then he was having more exacerbations, yes, ICS I will add, but I will also review the inhaler technique. Same thing in mind. We have reviewed this. Patient with severe COPD, GOLD group D, start with LAMA, then LAMA-LABA, then LAMA-LABA ICS. Then if the need be and if they have further exacerbations, I can use roflumilast or I can use macrolides. But in between, we will also teach them inhaler techniques. Okay. So there is data to show that the triple combination does work. And as we are going forward, in next 5 years, we'll have more just single-use inhalers, which have all the 3 formulations. And this data is from here. It shows that patients who are on inhaled steroids, bronchodilators, and anticholinergics, they actually do better in terms of exacerbation rates as compared to those who are only on inhaled steroids and LABAs. There is further data to show that triple combination does stabilize patients' lung functions as compared to those who are on inhaled steroids and bronchodilators. It also improves patients' symptomatology as well. Okay. With this information, let's move forward. James calls you after you have started him on three inhalers, inhaled corticosteroids, LABA, and dry powder inhaler, which has inhaled anticholinergic in it. Since the switch, he felt more breathless and experienced another mild bronchitis flare. He wants to change back to his prior thing, but I'm sure it sounds familiar. It's going to cost him now, because of change of insurance and all that, another $100. So what should you do? Ask him to demonstrate the new inhaler, change him to a nebulized ICS, add oral steroids, or increase the ICS dose.
Give us just enough light to lay down underneath the stars. Listen to Papa's translations of the stories across the sky. We drew our own constellation.
Again, half. I don't know, I'm stuck at half this time. Half the people said to teach the technique. Others thought we should go up on inhaled steroids. Folks, you and I just agreed that in patients group D, they are at risk for pneumonia. So I would not be very comfortable with just going up on inhaled steroids just as a knee-jerk response. We also agreed that oral corticosteroids probably has a very little role in COPD. COPD is a neutrophilic problem. Steroids do nothing to neutrophils, and if they did something to neutrophils, you'll be treating pneumonia with steroids. You don't do that, do you? So we will not use oral corticosteroids as a standalone therapy in COPD patients, absolutely. And we'll not increase the dose of ICS for the reason I've told you, because this is the group which is at high risk for pneumonia. In this thing, first thing I would do in my patient is to review his inhaler technique to make sure that is being done properly. Sometimes non-invasive, least costly interventions are probably much more better than most invasive and most costly. So I don't want to go away with that. These inhalers are simple. There are 5 different inhalers that are available today, some of which I'm sure everybody is familiar with. Meter dose inhaler, which is like your albuterol kind of thing. Patient inhales with a hand-to-mouth coordination is absolutely required, and you're told to take a small breath, but controlled nice way. Soft mist inhaler is a modification of that. It takes away a little bit of hand-to-mouth coordination, so it's a little bit easier on the patient. Cost goes up. We're all aware of the nebulizer, in which patients who have even poor hand-to-mouth coordination, they can use it, but it is cumbersome for the patient and to set up. You can also have a spacer device for some of these patients, it will help. The other form of inhaler, which means kind of made a comeback and rather are being more and more used, is called as dry powder inhaler. In the dry powder inhaler, you put in the capsule or once you press the device, the inhaler releases the medication, but the caveat is you have to have a good inspiratory flow. If patient can't do it, this device medication doesn't go into the lung, it stays in the mouth. So there is a little bit of trick involved in selecting which kind of inhalers. Patient has a good hand-to-mouth coordination, go with MDI, etc. If not, your nebulizer, or you can use soft mist. With the DPI, you must make sure patient knows how to take a good hand-to-mouth technique, along with that, a good inspiratory flow. So why is it that still we are not doing such a good job with it? It's because teaching inhalation device methods takes another couple of minutes in the office, and patient gets physician's time is in play there. Also, patient's understanding of this is rather difficult sometimes, and like everybody else, we do forget things unless and until it is reminded repeatedly. So there are some clinician factors. If I were you, I would learn a few inhalers, but I would learn them properly so that my staff, my MOAs and respiratory therapists and others can teach them. I want you to think of it as in this way. We are at 3, D, D, and D. For optimum management of COPD, when I was growing up, it was doctors, device, and drug. Take doctor away, it should be HCP, D, and D, healthcare provider, drug, which we have so many of them, device. It is the interplay of these 3 which actually gives you the optimum outcome. And for choosing an inhaler, I want to look at C, C, and C. Patient's coordination, patient's comorbidities. If patient has glaucoma, urinary retention, LAMA may be a little problem. If patient has tremors, coronary artery disease, LABA, I have to be careful. So comorbidities do play, and correct inspiratory flow. C, C, and C. Patient's coordinations, patient's comorbidities, and correct inspiratory flow. Forget about this lecture today, but if you take these 3 acronyms, D, 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 and C, 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 I would feel rewarded in my own way that something got delivered. Patients' adherence to inhalers is poor, where even with their bigger problem is not having been told about the peak inspiratory flow rate for dry powder inhalers, but also if they have to do multiple times, multiple errors, and anything which has to be taken more than twice daily, or multiple times daily, or multiple times single, patients don't want to do it. An average American above 65 in this country is usually on 6 to 7 medications, leave aside the multivitamins they are taking. It is not possible for them to keep that information intact and be compliant to this. And coupled with that, we know that, at least in COPD patients, because they have significant comorbidities, the adherence decreases for the inhaler use over a period of time. Inhaler misuse is much common. Okay, so with that little information, you and I agree. According to the GOLD recommendations, how often should healthcare professionals assess inhaler technique in a patient with COPD? I make a lot of questions. I'll tell you the story. Daylight come and we want go. Work all night and a drink a rum. 2/3 of the audience agree with me. I'll tell you a little trick for answering questions. So my first thing, if you don't know the answer is C. The other one is, if a question has always or never, that usually is the answer. Greg, we got to change this question. Okay. So point well taken. The GOLD guidelines do teach us that in addition, one more time, SABA, LAMA, LAMA-LABA, and LAMA-LABA ICS, at every visit, I will check the patient's inhaler if you want these medications to be effective and you want your patients to have an optimum outcome. So as a healthcare provider, I will try to know a little bit about these inhalers, know how they work, make sure my staff knows how it works, and they reinforce it every time that the patient comes for a visit so that patients don't forget about the proper use of these devices. move forward. Now, James, you have optimized him on inhalation devices. You gave him triple combination. He's doing well. Now he says that, you know what, it has helped my shortness of breath. But he comes to the office, you check him. As baseline, at room air, his saturation is good, above 90%. You do a 6-minute walk test, he desaturates. What would you do? At this point, give him continuous home oxygen, or tell him to use oxygen during ambulation, nighttime oxygen therapy, or refer him to pulmonary rehabilitation. I'm talking about from evidence-based medicine.
Something happening here. What it is ain't exactly clear. There's a man with a gun over there, telling me I got to beware.
Okay. Again, around 2/3 of the audience is referred to a pulmonary rehabilitation. That is the correct answer. Why is it that patients who are whose normal saturation is above 90%, if they desaturate a little bit during oxygenation, supplemental oxygen is not going to be the answer. It will not improve the outcomes. But yes, pulmonary rehabilitation will. There are only 2 non-invasive things that we can do for our patients. One, smoking cessation. Absolutely, all of us will agree, will help improve the outcomes. And secondly, pulmonary rehabilitation in our patients, coupled with that, up to date with their vaccination status, which all of us do anyway. So how do we use oxygen in our patients? They have to have a PaO2 less than 55. Or 55 to 60, but they have to have right heart failure. And the guidelines say you give them oxygenation, it should be more than 90%, but please check at 90 days that the patient needs it or not. And this I see a lot of time being missed. We start patients on oxygen and then we forget about it. So long-term oxygenation in patients who desaturate during exercise only does not improve the outcomes, as it shows that the outcomes of the hospitalization rates were more or less the same in both the groups. The treatment for this group is rehabilitation. Rehab improves muscle strength, it improves depression, it improves osteoporosis, feeling of well-being, and that is what we need to do for our patients. Adherence to COPD medication is poor. I've already given you information on that. We need to be able to remind our patients about the continuous use or the correct method of their inhalers. There are multiple factors to it. These are patient factors, physician factors, device factors. Patient factors are patient education. Once patient realizes the benefit, they usually will adhere, but since it's not a muscle memory, they will forget. We need to remind them again. As a physician, I must know my inhalers and actually figure this out, looking at my formula of C, C, and C as to which kind of inhaler I need to provide for my patients. And lastly, patient educations. It is important. The more the patients know about their disease, the better are the outcomes. It's been shown in asthma, it's been shown in COPD, and many other myriad of diseases. Some of them are being discussed today, including diabetes, etc. So recent studies, how do we improve our outcomes? EMR is a necessary help in that. Reminder to our patients, simplify the treatment. You can do home visits or phone calls or self-monitoring devices. They are coming. We'll have more of self-monitoring for COPD as time goes. So education for the physician, for the patient, for self-management is important. Monitoring should be focused on dosage, the correct techniques, and the side effect of your treatment. So what I talked about, COPD is a heterogeneous disease. It has multiple dimensions. Today we diagnose on the basis of PFTs, but we treat on the basis of patient symptoms and exacerbation rates, A, B, C, and D. A, short-acting beta agonist. B, LAMA-LABA. C, LAMA-LABA or LAMA-LABA ICS. D, LAMA, start with LAMA, then LAMA-LABA, then LAMA-LABA ICS, then roflumilast. But all 4, you will give them teach them about inhaler techniques and go from there. With that little information, and I know that lunch is coming, so please, we'll take some few questions. I also will talk about a little bit. We do have a person with alpha-1 antitrypsin. I'll invite her so that she can talk about it. And if you're interested in PFT, at NACE, there is another program that I've recorded on pulmonary function tests and spirometry and how to use spirometry and how to do spirometry. Please ask NACE people, and you can log on to it and learn that as well. Okay, with that information, after completing this activity, how confident you are about your appropriate inhaled therapies for patients with COPD, etc., etc. Likert scale, things have changed. Where are we on this in terms of either we are not at all confident or we are very confident? Thank you. Okay. After completing this activity, do you intend to use spirometry for evaluation of a patient with dyspnea, triad of shortness of breath, cough, sputum? Never to 5 to always. It's a Likert scale. Thank you, and I hope you people use it and find it rewarding. Few questions. Our first patient had 54-year-old woman with COPD, dyspnea score higher, but had no exacerbations. What score is, what gold criteria is this? She has no exacerbations, but higher symptoms. We call that as, I'll do that, I have a gun on my head.
On and on and on and on and on it goes.
Thank you. Gold B, as we all agreed on this. Next question, and since Gold B, current medications, if she's only on SABA, what we will start? We'll add a SAMA, or we'll start with LAMA-LABA, add inhaled corticosteroids, or add roflumilast. What should be the treatment for Gold B? What the choice is given here.
When you whisper me your best moves, I almost believe you, but you don't know me at all.
Add LAMA-LABA, thank you. And let's go forward. This time patient has more severe obstructive lung disease, more symptoms, and more exacerbations. So kind of higher exacerbations. This patient's only on LAMA. So what is our next step? This is a Gold D question. Add a LABA, add theophylline, discontinue metoprolol, or just change to inhaled corticosteroids. What will we do for our patients? This is a much significantly severe COPD. Patients only on LAMA, not symptomatic. Thank you. We'll add LAMA. Remember, SABA, LAMA, LAMA-LABA, LAMA-LABA, ICS, teaching the technique all the time. Next, please. And according to Gold, we should be doing this, teaching the inhaler technique or assessing it from our patients. I've already given you my bias on this. Every visit or never, or once a year. Every visit. And lastly, if patient has severe COPD like the one that we had, but he's still, baseline saturation is normal. He desaturations on 6-minute walk test. What is the best treatment? Continuous long-term oxygenation during ambulation, nighttime oxygenation, or pulmonary rehab. Thank you. Pulmonary rehab, of all the things, pulmonary rehab is probably the least utilized kind of thing in COPD. Please pay attention to it. Thank you very much. I'll take any question, comments, or jokes at this point of time.
So before you guys run out, we're going to do some Q&A, but then I have somebody to introduce to you. So let's take any questions on COPD. Anybody want to ask anything? Right here.
Yes, please. I can hear.
For insurance, what do you think the percentages of people who lie and don't take exposure?
Can you repeat the question for our audience at home?
The question is an interesting one, more of a social question, that insurance companies charge more for patients who are actually smoking. So what is the percentage of patients who are lying? That's not part of our CME lecture, but I can tell you, don't quote me, it's variable everywhere, but up to 1/3 of patients, yes. Yes. The important thing is that it should not be held against it. I think patients should be treated. COPD is like an addictive process, and it should be treated. Yes. Yes, please.
How do you deal with the patient that comes in and says, but the steroid worked last time. My regular provider always gives me steroids.
Okay. You know, I told you that COPD is a heterogeneous process, and there are some people who have a small bronchodilator response with that. Absolutely. I would go with inhaled corticosteroids in these patients. Long-term steroids causes more osteoporosis, more infection, etc. You got to argue with them, or at least explain to them that if giving inhalation only to the lungs is better than giving oral medications. It's easy to write in prescription than to go through the steps that I've talked about. That's where I think you and I fail. It's not a kind of stigma. That's how the practice has evolved. But give me a patient, and I'll show you how you can use inhaled corticosteroids in that patient. Works.
I have a couple of questions I'm going to combine. Someone is getting confused if they're doing spirometry for chronic cough and they get mixed results with a restricted pattern. How do you further evaluate those kind of patterns? And a second follow-up was about theophylline, about when you ever use it. So if you could address those
things.
two.
It's a very important question. On spirometry, a restrictive pattern means the FVC is down, FEV1 is down, but the ratio was less than 0.70. You have to check that the inhaler technique, the spirometry was done properly. Yes, there will be some patients who have a combined defect. Obesity with COPD will have that, absolutely. And if you're really concerned about it, then patients should have a full pulmonary function test and they should be referred out. But I can tell you, of the thousands of spirometries that I see, majority of them are not done properly because the patient didn't take a deep breath out, and that's why the FVC looks low, and you look like having a restrictive process along with that as well. I think this is very well explained in our lecture, and if somebody wants to look at it as to how to distinguish between the two on the NACE website, I think it is there.
The second part of the question was theophylline. Is there a role for it anymore?
Theophylline has three roles. One, it has mild diuretics. It increases the contraction of the diaphragm. It also causes bronchodilation. No question about it. But as in life, nothing comes easy. It has a very small therapeutic window. And these patients are on so many medications. So I hardly ever use theophylline in our patients. Yes, patients who have combined CHF and COPD and have nocturnal cough, you may be able to get by with theophylline in those patients because it will help. But only caveat is you want to make sure that theophylline levels are the same. So I usually don't recommend it in a primary care practice that they should be pushing theophylline.
And someone asked, what's the 3 C's? Coordination, comorbidities, and
correct inspiratory flow.
Correct inspiratory flow.
It's been very easily. You want to ask the patient, take a deep breath in, and then if they can do it or not. If they can, fine. There are devices available to measure the inspiratory flow. I'm not recommending that. Yes.
What's the role of, if any, for modafinil in COPD management?
Modafinil is a wakefulness promoting medication. I see sometimes being used to treat the so-called fatigue in those patients. I don't think I can recommend modafinil in treatment of COPD. It may have some role in patients who have COPD and severe sleep apnea, and after optimization of CPAP and other things, and they still are sleepy and fatigued. That's a very small window. One word about modafinil, it does affect your anticoagulation. COPDs are also on warfarin and all that thing, so please be careful writing about modafinil on your patients. But there may be small subgroup that may work.
So yes. I know there are a couple other questions, but I wanted to introduce somebody to you, and when I get the opportunity in our programs to meet real people, it always makes a difference. So Angela, can you come to the front? So one of the things that Dr. Talwar talked about a little bit here, we've done it in the past, we talked about alpha-1 antitrypsin deficiency, and NACE has actually partnered with the Alpha-1 Foundation for years, and they always have a presence, and these patients are out there and we just never find them. So Angela happens to be our local representative here in San Diego, and she's an Alpha-1 patient, so I thought it would be worth a couple minutes to just hear from her what her own experiences have been and maybe inspire us to find more of these patients. So Angela, can you tell our colleagues a little bit about your story and how you got diagnosed and where you're at today.
Well, my name is Angela. I'm 37, and I was diagnosed with alpha-1 antitrypsin deficiency and COPD when I was 32, after being seen by 5 pulmonologists who missed my diagnosis. And I was lucky. I only waited 2.5 years for a diagnosis. Most alphas typically are seen by 5 physicians and have to wait 7 years for a diagnosis. Most patients go through a lot of a very long journey trying to get diagnosed, but because you guys are all primary care physicians, some of the stats that I'd like to share with you guys are COPD patients are primarily seen by primary care physicians, 70% of them, and COPD is the 3rd leading cause of death in COPD, and 1 to 3% of COPD patients have alpha-1 antitrypsin deficiency. So the American Thoracic Society recommends everyone with COPD being tested for alpha-1 antitrypsin deficiency. And it's just a simple little blood test.
Right.
So.
And what was your life like before you got diagnosed? What were your symptoms?
Well, before I was 30, I was very active. I was running, hiking, biking, snowboarding. And then when I was 30, I started getting really short of breath, and to the point where I actually had to stop working. And I was on a lot of steroids, prednisone, Advair, Qvar, and 4 nebulizers of albuterol a day, and none of those things were working.
And now that you're diagnosed, what's your life like on therapy?
Well, with alpha-1 antitrypsin deficiency, it is separate. It's different than COPD, and the fact that we have a treatment that's a weekly IV plasma product. It's a plasma product of protein, of the alpha-1 protein, that replaces our alpha-1 levels that we're deficient of. Since the alpha-1 protein is made in the liver and it goes through the bloodstream to the lungs to turn off the inflammatory response, being deficient of this protein, because it's misshaped and it's stuck in the liver, my lungs were unable to turn off the neutrophil elastase process.
And how do you feel now?
A lot better, actually. But I have fewer exacerbations, and actually the plasma product that I'm on, they saw before they had this treatment, the average lifespan of an alpha was 55, and with treatment now they're seeing that alphas the average life expectancy is over 65.
Awesome. So I'll open the floor up to any questions before we wrap up. Dr. Tower, if you want to come up here, I'll come running to the audience. If you guys want to ask any questions.
So you can see an obstructive lung disease COPD pattern less than in 20, 30 years of age. You got to think of alpha-1 antitrypsin. You also have to think in patients who have low predominant emphysema on a CAT scan, that is COPD. 3% of the population of COPD patients generally in this country have it. Half of these are not diagnosed, so we need to diagnose them as well. Yes,
so
please.
that was a little bit of my question, which is that I do several alpha-1 antitrypsins a year just for screening in people with less tobacco use. And most of them come back normal, but the range of normal in our lab is pretty wide. And, you know, we all see that there are people who get COPD with relatively small amounts of tobacco and other people who can smoke 3 packs a day and never get it. Do you feel like those people at the lower end of the normal range who don't meet technical deficiency, that's part of why they're becoming more symptomatic? Is there a subclinical thing, or is it a yes or no?
You can get at level as well as the phenotype. The ZZ phenotype is the one which usually develops significant COPD. But you have MZ and SZ type. They may have borderline levels, but they need to be followed. If you have alpha-1 antitrypsin deficiency, normal levels, you need to follow them. Because once the levels decrease, then that's the only time when you treat them. But yes, you have to screen patients, and you will find patients who have, once in a while, you will find patient with COPD who has alpha-1 antitrypsin. In them, we do everything that we did here, including then we put them on alpha-1 supplementation therapy.
Okay.
And the manufacturers have free test kits for alpha-1 antitrypsin deficiency. But once you find an alpha-1 patient, then there's a free confidential test through the Alpha-1 Foundation on their website.
Right.
That's to reconfirm.
So hopefully this is helpful for all of us here in the room and at home. It's about 12 o'clock, so we're about out of time. Dr. Tawar, I want to thank you for a great talk on COPD today. And he's not running out just yet, so if you have any unanswered questions, he'll be happy to stick around, I hope. Okay, so we're going to take a break. Everybody at home, it's 12 o'clock here, just 12:05, so 1:10 Pacific time. We'll be back here. Everybody here, lunch will be downstairs, and they'll direct you outside. So thank you very much, and we'll see you in a little bit.